Okay, we got it. I'm all set. Thank you. Okay, so I'm going to run through and introduce you to healthy people. You heard about that yesterday from Meg. We have an almost identical slide, actually. And I'm going to do it fairly quickly because my presentation is a little bit different qualitatively from the ones that follow. But I wanted to, in fact, this was useful for me to go back and look into the history of healthy people. And this first slide just lets you know that it is run by the federal government, but it was really meant to be much more than a federal program. It was crafted, sustained really as a national initiative. And there's a lot of outreach that goes along with this, which doesn't involve my activities so much, but there are a lot of people involved, and you'll see that soon. One of the central concepts are the objectives are quantified, and the ideal is to obtain measures across a decade. Well, I thought it worked. Here we go. I have to remember the trick. This started out with just 3 areas back in 1990 for the objectives. It grew probably to 20 or so by year 2000. The year 2010 objectives, there were 28 chapters, each with multiple objectives. And now by 2020, there are 42 topic areas, each with numerable objectives. So obviously I can't cover this. The difference between 2020 and 2010 is that vision and hearing were just one chapter in the past. But now we have hearing, and we've expanded it to include the other mission areas of the Institute. Okay. This can be the bane of my existence. Everything done in healthy people has to pass through this committee. I can't change a single word on a single objective without more or less unanimous support by all of these people who sit and meet every month and go over all the fine details. It's incredible. But what it guarantees is quality and uniformity, and it works. It has worked. The NIH appears to have 2 representatives. Martina was for 2010, and she's an alternate now. And for NCHS, which is a key player, there's 1 person. And the director of all of this, it's run out of the Office of Disease Prevention and Health Promotion, is Carter Blakey. She's deputy director, and or her boss, whomever is at that time. Okay. Well, how do we track objectives for healthy people? We need data, and we learned this the hard way. In 2010, we came up with a questionnaire for the health interview survey. It went into the field, and then they said, oh, and you have $1 million to pay for this? Oh, well, no, we hadn't been told we had to have $1 million to pay for it. So those objectives, I mean, that survey was yanked. We came back in 2002 with a much shorter survey that we could afford to pay for, but that reduced an awful lot of the questions that we could address. One difference between vision and hearing, and since this conference frequently talks about both, is that for the vision objectives, everything is based on report data, which is what the health interview survey is all about. You can see here the history of the NIDCD supported parts of the health interview survey. It has been expanding, and it's expanding in part to address questions that are in healthy people. Example of what we can learn from the health interview survey, and I don't know of any other way to learn this, is etiology, or some attempt at etiology. And of course we all know, we think, but now we know from what people say, that aging is what primary. Among this is all adults, what was the cause of your hearing loss? Of course, a lot of it's present at birth. A lot of it may be noise-induced. But this is what people say, and this was in 2002. Okay. For us, hearing, we wanted exam-based measures, at least in part. And that meant that we had to fund, and we were continuing to fund, health examination surveys that included hearing in NHANES. Before I joined the Institute, NHANES 3 was well underway. It was continuing when I first joined. And there was a question in '94 whether it would ever come back into existence because they stopped it. Now it's a continuous survey. It should never stop. But in fact, in 2013 and 14, we don't have hearing yet. We're doing smell and taste instead. We had to choose. But anyway, we can't, the surveys are much smaller. I put the sample sizes here than they are in the health interview survey. And we do only certain selected years at a time. So this does limit the data we have to put in for healthy people. Now, but what can we learn from the combination of health interview survey and NHANES? Obviously, we can learn about hearing loss both from threshold measurements, the impairment side, and from report, hard of hearing, and other questions. We learn a lot about tinnitus. How else would we learn about that except through the health interview survey? We learn how recently they've had their hearing tested. We can ask questions about use of hearing protection and use of hearing aids. And of course, the advantage is all these two surveys have a lot of other information about comorbidity. And the design, back when I first joined the government, we would not have known how to analyze such complex sample survey. But that methodology is caught up, so we really have great tools. Okay, now the new 2020 hearing, other sensory or communication disorders, for short, ear, nose, throat, voice, speech, and language, consist of of objectives within all of these areas. Probably the most objectives are within hearing, and that's the only one I'll focus on today, and I'll only tell you about a few of them. And here's a slide that you saw, I think, with Meg. The only difference is I have broken out the sub-objectives that we actually have been tracking. So this objective 3 in 2020, increase the proportion of persons with hearing impairments who have ever used a hearing aid or assistive listening devices or have cochlear implants. We did it because of the NHANES structure. We test from 20 to 69. So we had to have one objective for that age range. And then later, when we were able to implement hearing testing in adults over age 70, we added 3.3, but it's the same goal, but it's split out by age. And in between, we were doing cochlear implants, and that's for people of all ages. Okay. The other thing to point out, I think, from this slide is, and this is not something we had much to do with, it's the same on this slide, the targets are really softball, 10% improvement. Of course, a lot of things aren't improving at all, but they're not meant to be unreachable targets. They're meant to be something that could be achieved. And that's something that originally we had a lot of latitude working on our individual committees, but more or less is now a uniform decision, 10%. That's what you're supposed to do for the decade. This next question, increase the proportion of persons who have had a hearing exam on schedule. You can see that the baseline is sometime before 2010, and then the target is for 2020. And again, we have this age split. Okay, this is a typical, it's complicated, but this is a typical diagram or graph that comes out of this healthy people approach. We look separately within the two age groups at gender, female and male, and we look within, and arbitrarily, we choose this, to look within age-specific categories. And I think this slide, this is hearing examinations in the past 5 years. It's just coming from the health interview survey. And you can see that more men, I'll do this right, more men in the under 70 age range than women were having hearing exams. In that age range, more men report hearing loss. So in a way, it goes together. And you can see that with age, there's still some difference between males and females, but the 80-year-olds have more, and the 70 to 79-year-olds have more hearing exams than the younger. This is natural. This is what you would expect. But you need to show it. Okay? Maybe you can move this. There we go. Okay, so data collection for healthy people is rigid in the sense that these are the categories. Race, ethnicity. Now they've changed for 2020, but this was for 2010. The categories for education and income had to at least include these. You might get finer detail if you wanted. and of course gender, and this is geographic location and disability status. There are now more categories. The interesting thing to learn is that none of this is cross-tabular in that we look at income by gender by education. It's not multivariate. These are just the cross-tabs, okay? Sorry, let me go back. These are the data we have collected on use of hearing aids, and you can see the top, doesn't say it here, but these are the 70, sorry, myself organized. These are the 70 plus, and these are 20 to 69. And there is a gradual tendency to increase, at least in the 70 plus. Okay, new cochlear implant surgeries, we're particularly pleased to have this data. And I think to point out, for children preschool children under age 6, this 15,000 per, 1,500 per 10,000 is around 15%, not higher, 15%. And that's for pure tone loss estimated greater than or equal to 70 dB, hearing level, pure tone average. Okay, I put this slide in, it may spark discussion later. Some of the goals we established, of course, took off. One of them is for newborn hearing screening. There's considerable progress there. And then finally, discussion. The Healthy People program, as difficult as it can be and exasperating at times, it does provide this national focus. And it's very important to have hearing health and other communication disorders side by side with heart disease, diabetes, and all the other things that are there. The goals must be national in scope, but they're also meant to be useful for state and local, objective, quantifiable, and they must be ascertained periodically. If you can't collect the data, you can't have the goal in terms of the healthy people. The other thing is we have seen clear examples of success with newborn hearing screening and those with more moderate gradual improvement, perhaps for the use of hearing aids for people 70 and older, and I think that's going to be one of your topics to discuss. There's a lot of background literature, some of it just now coming out, on why Healthy People was created and how it's been sustained. And then finally, for 2020, this is kind of, and 2010, the sampling of all the people that had a hand in this. Now some, like Meg, might want to know more about it and be more involved, and that's always an issue because there's so many people involved. But my struggle in the Institute is to come up with the data for the progress reports that will be looming ahead. Okay, thank you.